primary care payments released a third final rule with another 100-something pages. So a little bit of work, and to suffice it to say, I haven't finished reading all those pages yet. But what I wanted to do today was dwell on three broad topics. The first topic was this final rule that came out yesterday that spells out a lot of the bells and whistles on the 2013 payment system for physicians. I'd like to spend another third of my time talking about the health delivery system reforms. I'm going to touch on these. I'm not going to go into a lot of depth because I know a little bit later today you're going to be hearing more about some of these. And then I also wanted to talk about what happens after next Tuesday. So in terms of the physician fee schedule, I'm not going to cover the whole waterfront. What I decided to do was pick these 6 topics, and I'm going to go through them. I have a slide or two on each of these topics. The first one deals with global surgical services writ broadly, and I want to talk about the kinds of issues, what's going on within CMS. I'd like to talk about some initiatives they are moving forward on for primary care. And you might say, well, why is he talking about primary care here? Because, typically we're not viewed as primary care physicians. And you'll see in a moment why I'm doing that. The third issue has to do with the ordering of portable x-rays. And the fourth one has to do with new rules now that will be coming in place with respect to the ordering of durable medical equipment. And I know that some of these will be affecting you and your patients. I also will touch on some of the physician quality reporting system changes. And lastly, this new creature, this new policy, the value modifier. So let's move on. The misvalued codes, as you know, CMS used to do 5-year reviews of relative values. They're now doing annual reviews. They're looking for potentially misvalued services and trying to dig into that and trying to see what changes need to be made. It's kind of a stay tuned topic, and that is CMS is very suspicious that when they look at global surgical services, that physicians and other practitioners actually are not furnishing many of the evaluation and management services that are assumed to be part of the service. So if the average amount of post-op care would be 3 office visits, they're beginning to be suspicious that there are never 3, that maybe there are 2, maybe there's 1. And so where that's going to take us is they're going to continue to scrutinize this area, I have no doubt. And the danger here is that depending on their findings, we could see global surgical services being valued downward under the Medicare program. And so that's certainly something to pay attention to. Now, as part of the proposed rule they issued earlier this year, they asked everyone out there, where could we go to get better data about what's actually going on with respect to the global surgical services? How much preoperative service, how much postoperative care is actually being provided? The second issue has to do with things that are rolling down and some potential future initiatives to increase payments to primary care physicians. And typically we're talking about internists, family practitioners, in some cases pediatricians, in some cases geriatricians. So we're talking about that family of practitioners. And in this final rule, one of the things they are going to be doing is they're going to be making extra payments, generally to primary care physicians, for something they're calling post-discharge transitional care management. And truth be told, it's kind of like care coordination after someone is discharged from a hospital or a nursing home. And these are typically viewed as higher risk patients that they might get readmitted if they're not properly handled. And so responsible community physicians will be able to get an extra payment to cover things even like phone calls, to cover things like having their office staff work with Mrs. Jones after she's been discharged. And I tell you all of this not because you're likely to be the beneficiary of these new payments, because you aren't, and the same would be true for most specialists. But I tell you this because this is a new wave, if you will. And the second wave behind it that they're already talking about is the possibility of making extra payments to what they'd like to call advanced primary care practices. And what they haven't figured out yet at CMS is how are they going to define what an advanced primary care practice is. And why this is all important is when CMS does this through rulemaking, it has to be done budget neutral. And so the effect then, every time there's an extra payment made over here, there's good news for somebody, but it has to be offset. And as I show you there in the last bullet, for you, for this go-round, these new payments for transitional care management have the effect of reducing payments on average for podiatry by 1%. Now, before you sort of panic about all of this, I mean, it is an important issue, I will also point out they did something else in this final rule that gave you back the 1%. And that is they made some adjustments in how they take into account the interests for purchasing expensive equipment. And so they have been assuming in the formula for relative values very high interest rates for loans for acquiring expensive equipment. And they're now going to adjust that downward. And so they took away 1% in this way, but they gave back the 1% to you by this other change they made. Well, let's go to an issue that you have been interested in. Certainly APMA actually was responsible, I think, for what occurred in this final rule. And that is, for a very long time now, Medicare has said that the only folks who legitimately can order portable x-rays are MDs and DOs. It's been a long-standing rule in the program. APMA members, some of them were concerned about this, feeling this was out of date, needed to be updated. APMA representatives went to meet with CMS. There was a lot of back and forth. Lo and behold, in the proposed rule, CMS proposed to change this, to update its regulations to account for scopes of practice. And it was successful. The final rule now confirms that doctors of podiatric medicine may order portable x-rays, presuming, of course, that their scope of practice in their state provides for that. And I believe our view was that would be the case in every state in the nation. And so, again, this is an update, this is a change in Medicare policy that APMA had a direct hand in. I mean, problem was identified, APMA went through the steps, APMA was successful in this final rule. The ordering of durable medical equipment, it's a complicated area, but I want to dwell on this new requirement. What CMS has basically done is they've identified a group of codes for durable medical equipment. There's a long laundry list of those codes, and they're basically going to impose a new requirement. And that is, in order to legitimately order such DME, the physician, or in some cases, certain physician extenders, are going to have to do a face-to-face encounter with the patient. And this is viewed as a way of precluding ordering unnecessary equipment. It's presuming that this will be better for the patient at the end of the day. So as you see in the final rule, there's a list of 166 HCPCS codes that this new policy will apply to. So again, now the visit itself, they've decided in the final rule that the visit would need to have occurred within 6 months before the order is written. So it could presumably mean that the patient came to you 2 months ago, and now you're ordering one of these pieces of DME, but you don't need to have a new visit. You had the visit before, assuming that visit was related to what you're now ordering. Now, in order to give more time, and you're going to be hearing a lot more about this over the next several months, but in order to give more time for people to understand what this is, how it's going to work, et cetera, they've delayed the effective date of this requirement until this coming next July 1. So again, you'll be hearing about a lot more. I've given you a few examples there, but just a few of the kinds of equipment that are affected by this new policy. Wheelchairs and accessories, pneumatic compression devices, neuromuscular and osteogenic stimulators, and so on. There's a long laundry list in the final rule of the services that will be affected. Now, this is a very curious thing, I have to say, because if you look at the next bullet, you might want to join me in scratching your head. Because what CMS is saying here is they believe this is going to reduce Medicare spending for DME by $85 million over a 5-year period. But it's going to impose a net cost on the whole system that's going to be significantly greater than that, of $172 million over the next 5 years. What's that $172 million? Well, it's extra payments for these office visits that might not have needed to occur. I didn't go into detail, but when a nurse practitioner does the encounter, it can't stop there. A physician must sort of document officially that that encounter took place. So they have to co-sign the medical record. And to reward them for that work, believe it or not, they're going to pay them for doing that kind of documentation. And so that has to be applied on a budget-neutral basis as well. So this is another issue. Now, beneficiaries are going to have more cost sharing for these encounters they're going to have to undertake. So it's kind of an interesting thing. And by the way, one of the things they were encouraged to do by APMA and lots of other folks was, you know, maybe this is a good idea, maybe it isn't. So why don't you start with a small list? Start with a small list and see how it goes. They essentially rejected that. They did pare the list back a little bit. They took about 10 items off the list, but they certainly did not make a very significant change. So at any rate, long story short, this is something you'll hear more about. And the last bullet is something to pay attention to, and that is there is a risk that the next reg that's going to come down is going to be proposing the very same thing for certain types of orthotics and prosthetic devices. And so, again, this is certainly an issue that you will want to pay close attention to. The next topic from the fee schedule I'll go briefly through, and that deals with the physician quality reporting system. I just want to touch on three things, because there's a lot in there. I think there's several hundred pages in the final rule just on this topic alone. First, group reporting has been an option, but the size of the group's been quite large, and now they're going to take the group size down. So if you're 2 or more physicians, you will be able to report as a group, at least in some ways, going forward. So this is a change that they're making. Secondly, remember that PQRS or PQRI that came before, you always heard, well, that's voluntary. You don't have to do it. And if you do it, and if you do it right, you get a reward. You get an incentive. Well, remember, we're moving out of that framework, and we're now going toward payment adjustment. So it's not voluntary anymore, really. And if you don't do it right, you're going to get a penalty down the road. And that's going to begin, the penalty phase begins in 2015 as a penalty, but to avoid the penalty, you have to do the right thing in 2013. So it's coming up right now. There's 2 important things that I want to highlight that are in the reg, and I won't do them justice, but there's 2 new ways you can avoid the penalty. The first one in that second bullet point I don't think is going to work or apply to you folks or to many other specialists. And this is something, it's called the administrative claims reporting option. And to make a long story short, rather than having to add quality reporting measures and so on, they're just going to take your normal claims and they're going to do some analysis on those claims, and they're going to use the regular claims to look at certain performance measures. And as you might imagine, that's going to limit what they're able to do and what they're able to look at. But this is going to be a new option for avoiding the payment adjustment down the road. So certainly large multi-specialty groups, large primary care groups are going to be able to take advantage of this. They don't have to do anything. Just send in your claims, and your claims are going to be analyzed. And so this is going to be one change. The next one, though, is going to be available to you, and that is they're going to be very generous in 2013. And basically, if you report one measure or one measures group, they're going to say you've done enough, and you don't need to worry about a payment adjustment in 2015. So at least this is something that's going to take, I think, a great deal of pressure off folks in the coming year. And again, you'll want to be paying more attention to all the details that go with that. It's just report. And so it really, you're going to have to work pretty hard, I think, to incur a payment adjustment in 2015. So I think that's the good news. And the last fee schedule topic is a very complicated one, and I'm going to really try to simplify it. You all know about the conversion factor under the fee schedule, right? Well, what we're talking about here in the value modifier is essentially another multiplier afterwards that can take payment up or down depending on your performance. Now, by and large, I don't think podiatry is going to need to worry about this in the near term. Why? Because as you see, what CMS is going to be rolling this out, okay? And the first application of the modifier will be in 2015. But again, 2013 is the important year because that's the year that determines whether you're going to get that payment adjustment in 2015 or how the modifier is going to work. But as you see in the second bullet, they have decided to roll this out gently and to apply this concept only to groups of 100 or more eligible professionals. So I would assume that most doctors of podiatry will not be affected in any way in the first round of this whole exercise. And that's, I think, good news, because I think both CMS and others have a lot to learn about how this is going to work. The other thing that in the near term they're going to allow is even these large groups, if they successfully report under the physician quality reporting system, they're essentially going to be deemed to be okay. Their value modifier could be at least 0, which means don't worry about it, we're going to leave you alone. Or if they want to take a risk and roll the dice, they can be judged under a fairly complex thing called the quality tiering methodology. Again, I'll say a little bit more about that. But this quality tiering methodology, in a way, is a way of looking at certain cost performance measures, certain quality performance measures, and comparing the group to other benchmarks and seeing if they're good guys or not so good. And if they're good guys, they could get a reward under the value modifier. If they're not so good, they could get a penalty. So in other words, they wouldn't get the full fee schedule amount, they'd get something less. Okay. But for the near term, if they're do okay under the PQRS, they could be left alone if they wish. Now, on the other hand, if they don't report under the PQRS successfully, they're going to be penalized by the value modifier of another 1%. So these big groups are going to have to be paying attention to this whole exercise. Now, the last bullet is important for you to realize, and that is under current law, this concept has to be applied to all physicians by 2017, which in effect means most likely that what you do in 2015 will be the key, because in 2015 your performance in that year will determine how the modifier will work for you in 2017. I wouldn't panic about all this. I think this law could certainly be changed. This timeline could be adjusted. There's a lot of complexity here when you try to do this in an individual physician or small group. When you're dealing with a group of 100 docs, there's a lot of things you don't have to worry about. But anyway, the value modifier is a very new concept. So as they did all the adjustments they did throughout the regulation, with respect to work relative value units and malpractice, it's a 0. For practice expense RVUs, you're a net winner. And the reason for this has to go back years when, remember, we did a new survey for practice expenses, and that was all collected under auspices of the AMA with all the specialties playing a role. You did very well in that exercise, and you're still benefiting from it because it's been phased in. This is the last year of the phase-in, though. So you won't have this kind of gain to look forward to in the next year. But as you see, the combined effect, on average then, what they're predicting, if we just look at relative value units, they're predicting an average of 2% gain for podiatry in the coming year. So again, I think the bottom line is reasonably good for your specialty, certainly compared to others that are net losers through this latest reg. I think some of the specialties are losing as much as 9 to 14% in 2013. So 2% gain looks mighty good in that context. However, as you know, this doesn't say anything about the conversion factor. So let's file that away, and we'll talk about it in a minute. That's my first third of my program, so maybe I'll have to talk faster for the other 2/3. Health delivery system reforms, 3 topics I want to touch on: the accountable care organizations, bundled payments, and other things the Innovation Center is doing at CMS. As most of you know, they created a new Center for Medicare and Medicaid Innovation, and they're rolling out lots of interesting initiatives. And so I want to talk about some of those. Okay, this slide gives us a little bit on where are we with accountable care organizations, and I just emphasize in the first 2 bullets how many of them there really are. They've been regularly approving, both through the Medicare Shared Savings Program and through the Innovation Center's unique program called Pioneer ACOs. And in the first 2 bullets there, you see that 27 ACOs were approved for an April start date. another 89 for July, and there's a new round for 2013 that's going to be announced in the near future. And the Innovation Center has 32 Pioneer ACOs. And as you see, if you tally it all up, the best estimate is almost 2.5 million Medicare beneficiaries are now being cared for through these ACOs. And so it's becoming a more and more important mechanism for actually delivering care under the Medicare program. Now, there's a lot of unknowns about all of this. How's it working out there? What do the patients think? What do the doctors think? Are they going to be able to save money and share savings, or what's going to happen? And I know that my friends in the technology community are extremely concerned that patients are going to be regularly denied access to new technology because it's expensive. And so ACOs are going to try to cut corners, and so they're worrying about that. What I would ask all of you to do is continue to be the eyes and ears for the association. If there's an ACO in your area, try to find out more about it, trying to feed back information. If you're participating in an ACO, similarly. And to give you a flavor, I've just listed, a few of what are now 148 Medicare ACOs all around the country. And I just picked a subset so you get a flavor for, may not be in your backyard right now, but it certainly might be in your backyard soon. And it's something you'll be hearing more about the ACO programs later today from another speaker. So let me shift to the next issue on delivery system reform, and that's bundled payment. This is at the moment an initiative within the Innovation Center. So it's in that part of CMS. And they had proposed to test 4 models of bundled payment. But one of those models, which only focused on inpatient hospital services, is on hold right now. Not clear where it's going to go. The other 3 models, as you see down below, bundle different types of care. So Model 2 says we're going to bundle the inpatient hospital care, the inpatient physician services, and some post-acute services as well. So that's going to be one bundle. Now, all these bundles, by the way, are triggered off a hospital admission. So you need to have a hospital admission as the starting point. So if you're providing a service that there's really no trigger point there, then it's not quite relevant. So what they're trying to do here, basically, is to take certain admissions, say admissions for total hip replacements or total knee replacements, and they're trying to bundle different type amounts of care and run a bundled payment system rather than the type of fee-for-service system that they're working on now. So then there's 3, so models 2, 3, and 4. Models 2 and 3 work like we work today. Everybody gets paid normally. So it's just everyone gets paid, but then they retrospectively do an analysis to see whether they are spent more than the bundle or less than the bundle. The Model 4, in contradistinction, is where they make a prospective payment to one entity that covers all of the care. So in that model, for example, you'll notice there's physician services included. So in that model, the typical formula would be we're going to pay the hospital for the bundle, and the hospital is going to work with its medical staff and others to figure out how to divvy up the payment. Now, for all these models, what do you need? You need to define the episode of care. How long is it? What's in, what's out? And so that's the thing they're struggling with now. So they are developing definitions of episodes for different DRGs, for different situations, including different amount of care. But it is something that some of the applicants for this bundled payment initiative could well have picked DRGs for some of the services that doctors of podiatric medicine do provide on an inpatient basis. And of course, the other issue, as I said, we have to define the episode. So at what point, conceivably, could some care provided by DPM to one of these patients somehow get caught up in this bundle, and how's that going to work? So again, something certainly to add to your list to pay attention to. Briefly, I just want to end by looking at the Innovation Center and making you aware of 2 initiatives. The first one is what they're calling the Comprehensive Primary Care Initiative. Don't need to get too detailed, but you see that they've picked 500 primary care practices in 7 markets. I list the markets on the slide, and I'm sure you're going to get this slide deck after I leave. And Practices, if they're playing in this initiative, are able to get a patient management fee, a monthly care management fee for each of their Medicare patients, and in most cases from each of the patients of the other payers that have joined in this initiative. And so these 500 practices now have a new source of revenue. They're not just getting paid for their discrete services. They continue to get paid for those. They also get this management fee on top of that on a monthly basis. And down the road, if they are able to save Medicare money, they will be able to share in those savings. So there will be that opportunity. So again, something the Innovation Center is doing. And the other thing the Innovation Center has just kicked off is focused at the state level, and they're offering interested states money to design and even implement multi-payer payment systems. So we could see some very different things out there as a result of this kind of initiative. I mean, the world is really changing. It's not that, you know, same old that we've been experiencing. So ACOs is certainly a change. The bundled payment would change things, as would a lot of these Innovation Center initiatives. So now for the last third, and I'll probably spend even less time here, is the post-election issues. And obviously a big one is what they're going to do on the physician fee schedule conversion factor and our friend, the sustainable growth rate. The other issue, of course, is who's going to be in charge. And lastly, what's going to happen to Medicare? So let me touch very briefly on each of these things. Here's, though, I'm going to let you in on a secret. This is what the medical doctors are planning if the SGR doesn't get increased. So, you know, they're going to switch with patients they're going to take care of. I don't know if there's anything in there for you, too, but I mean, I just thought I'd toss it out there. I thought this was kind of an amusing little slide. Okay, what's the latest on the update? Well, just yesterday, when they released the final rule, they basically told people that based on the latest information, that if Congress did nothing, the conversion factor would have to be cut 26.5% come January 1. And given what they've done in the regulation, remember there's a lot of budget neutrality things in the regulation, if that 26% cut took place, plus what they did in the reg, the new conversion factor would just be over $25. Okay? So this is the worst case scenario, I suppose. But I would expect, I find it hard to believe that anything like this would happen. What I think, though, is quite likely is Congress is going to just take a baby step before January 1. And say, well, we're going to, you know, we're going to do something for the first 3 months of 2013. So we're not going to make this huge cut. Maybe we'll, you know, extend the current conversion factor or whatever. And we'll figure things out come February and March when there's a new Congress, et cetera. Now, there's always the risk that they won't get their act together in time and that we'll have to reprocess claims come January 2013. But hopefully they will be able to at least do some short-term patch to deal with this. I think the difficulty, though, is what to do longer term, even longer term like 1 or 2 years, because no one really knows what to do with a sustainable growth rate. But they do know that if they make any changes, it costs a lot of money, that there's a budget implication. And the current gestalt in Congress is that if we're doing something that's going to increase the deficit, we have to offset it somehow. We can't just increase the deficit anymore. You see how the polling is going. It's going to be a very interesting thing to watch and learn whether we're going to retain the current administration or have a new one. And even if we retain the current one, there could be lots of changes in people and policies even in the next 4 years. The makeup of the Congress is going to be key and whether they're going to be able to work together. And there are interesting people retiring this year who've been kind of a moderating force and are going away, and so things could get even worse in terms of sort of no one wanting to talk to anyone or do any deal making. And this is an interesting little cartoon, but I think the truth of the matter is, yes, cut Medicare, because I think that's going to happen one way, shape, or form. It could happen later this year. It could happen again in 2013 as people look for money to offset the deficit, look for money to fix the SGR, or look for money in a host of other ways. And so while one party may point to the other and say they're the ones that are going to do that, I think the truth is they're going to do it. It's just going to be a matter of what it is that they're going to do. And the next 3 slides are just a way of kind of positioning you to think about this. Don't dwell on the details, but you'll notice that the real world projections of where we're going on Medicare, it's up, up, up. And so that's part of the context here for this budget exercise. If you look at the Hospital Insurance Trust Fund, you see it going broke. That's been predicted before, but this is another part of the context. And then if you look at these slides, you notice that whether we're talking about Part A or Part B or Part D of Medicare, it continues to consume more of the gross domestic product. And so yet another contextual piece of information as Congress sits down and does the budget. So what about Medicare? Well, what are the threats? Well, first, you've probably heard about sequestration. And that's a real risk come January 2nd. And that would mean an across-the-board 2% cut in all of Medicare spending, essentially. All Medicare payments would have to be cut by 2% if this sequestration goes forward. Likewise, huge cuts in defense and huge cuts in all kinds of domestic programs. So that's yet another thing that Congress has to deal with before we get to January 2nd. So that they're going to be pretty busy after the elections. The other issue, of course, as I said before, is they are going to be looking for savings in the coming year. And certainly the Medicare Payment Advisory Commission has been looking at a variety of topics like therapy services as one place to go to make cuts. And so there's a lot of vulnerabilities there as Congress does its work. And certainly as they go forward, it's quite possible that much more fundamental changes in Medicare would take place, either on the eligibility age or a new concept of premium support. So let me just, in my last slide, what I wanted to do was just touch on premium support. This is an interesting concept that could have more or less life after the elections, but basically beneficiaries would begin to make choices either among private plans or the traditional Medicare program, and Medicare would basically be converted into a defined contribution, essentially. They would, the amount of money that the government would give for coverage would be fixed in one way or another, either through competitive bidding or through some formula. And so if beneficiaries selected a more expensive plan, like they do today under Medicare Advantage, they would have to pay out of pocket. So this is viewed as a way of bringing more pressure on the system to become more efficient. And certainly there's lots of questions and controversy about it. But as you see in the last bullet there is a hope that this is going to prompt private plans to find innovative ways of delivering cost-effective care, gradually bringing Medicare spending under control. And so you'll, I think, be hearing more and more about premium support. So with that